I absolutely agree we got to do that germline testing because it's about identifying the patients at risk. Doesn't tell you what to do, but it lets you know who's at risk, lets you know, that you need to be on guard. And then the question is, how do we apply those same kind of standards of proof to all the other tests we might get? Because of course, it's just a crowded space. There's a lot of different kinds of tests. So I'm going to focus more on some of the other tests. I told you what I think about germline in the first talk, but I'm going to talk about some of the others and build upon this concept of proof. In localized prostate cancer, we know that this is a complex space. This is a space you all live in every day. These difficult conversations you have with patients about what does it really mean? What are the options for me? We all know that PSA stands for prostate-specific anxiety. We know the psychological part of prostate cancer is what we struggle with, and that's why these tests have become so popular, because of how they help us with the psychological part of managing prostate cancer patients. So it's that essential question, right? To treat or not to treat. When you talk about, and we talk about this in a couple of different spaces. We talk about it from the time of biopsy. Should we do active surveillance? Should we do active treatment? Or in a different space, we talk about those men who've had their prostatectomy, have some adverse pathology, and we're talking about should we radiate versus just do surveillance in those patients, and any number of other questions. And so ultimately these tests, right? These tests are all about how do you help that patient who's struggling with the decision? How do you overcome the indecisiveness, right? And the answer is easy. All you do is order the test and it gives you an automatic answer, no more further thought required. All right, so lots of different tests for different parts of the spectrum. Obviously in 10 minutes I'm not going to go over all of them, so I'm just going to go over some of the data because it's representative of the space. So the fact of the matter is none of these tests are routinely used. Uptake is relatively low. Most men go through their treatment without having at least all of these tests ordered, maybe one somewhere along the way. But results are inconsistent. And the fact of the matter is most of the studies are underpowered and they're retrospective. Most of them lack validation sets. Most of them are single institution. Okay, so it gets very difficult to compare data sets, and I'm not going to try to do that. What's useful about the test, the pro is the optimism, right? It's molecular, it's high tech, there's new methods involved. But the problem is statistical significance doesn't necessarily translate to clinical significance, and the other problem is that technical validation of a test doesn't necessarily translate to clinical validation of the outcomes, right? So some of this is a bit dry. We're talking about rules of evidence. But of course, the thing here, it's heterogeneity of disease that's what we're struggling with, right? This is all about predicting, a week out, where is a hurricane going to make landfall? And we all know how accurate those predictions are. We all have Gleason 10 patients who never progressed and are alive 15 years later doing great. And you have Gleason 6 patients who ended up having metastatic disease 3 years later. And neither of those make a lot of sense because, of course, Gleason is prognostic, but it's not definitive, right? There's always exceptions to the rule. So this causes a lot of confusion amongst patients, amongst providers. There's overlapping clinical spaces. There's difficulty with all these tests. I'm sure you have patients come in, they say, well, my neighbor got Oncotype, my neighbor got Deciphered, my neighbor got this, my neighbor got that, and it's a completely different scenario. And the problem is patients really expect that the test is the definitive answer. If I get a result that says X, then the response is Y. If I get A, the response is B, and they believe we're improving outcomes. And the fact of the matter is all we're really improving is on patient-specific anxiety. So, here's some of the tests that are available, slight differences between every test in terms of what tissue you need, what it's testing, what the utility of that test is. They're all running in that, $4,000 plus range per test. And unfortunately, this is what we're doing, right? We're giving that patient this false sense of security. Oh, you've got the answer, doctor. You told me I have extracapsular extension. You told me I have a PSA of 10 prior. You said I have a Gleason of 9. That's all well and good. Your opinion's fine, doctor, but the test tells me what I should do, right? Okay. So walking through an example. So this is the Deciphered test. This was the data, and this came out of my institution, right? Jeff Carnes, one of our surgeons in Rochester, did this. And they started with an initial cohort of 1,000 patients, 2000 to 2006. They identified amongst those 400 who had biochemical relapse, 73 who ended up with metastatic disease. They set up a case cohort study, right? So this was their initial, and then they got a validation set externally. And after 8 years of follow-up, 27% have BCR, 7% have metastases. And what they did was they validate their test, their genomic classifier, against all the standard metrics we're used to looking at, right? Extracapsular extension, Gleason score, seminal vesicle invasion, et cetera. And the way these curves work, right, the area under the curve, the more space you capture, the better. And what this says is your genomic classifier was the best compared to any of our conventional pathologic standards, long-standing standards for identifying high-risk disease. And that's all well and good. That makes us feel good. That's certainly a valid test. But the question is, what utility does it have, right? This is getting to the question of, is a successful test necessarily clinically useful? And this is why, you would say it is useful. This gives you a score. We know patients love numbers. That's why they love Gleason. That's why they love PSA. This gives you a score, right? A GC score of greater than 0.6 means your chance of metastasis is 22.5% at 5 years. Clearly higher, tenfold higher almost, than a GC score of less than 0.4. This looks valid, certainly useful. It feels good, right? But nevertheless, remember, this GC score of less than 0.4, you still have 2.5% of patients getting metastases, right? So it's not perfect. And this breaks it down a little further. So again, those patients who were high risk initially are qualified to have the genomic classifier done. Looking at their GC scores, remember 0.6 is high risk, right? 0.4, less than 0.4 is supposed to be low. And as you look at Gleason, the blue dots here are patients who never developed metastases. Red dots are patients who did. And the problem here is that still with a GC of less than 0.2, you still have red dots, right? So it's not perfect, right? You still have red dots here. And remember, this 0.4 line is the issue. So even though the classifier is good, even though the classifier improves upon, the prior methods, the fact of the matter is the classifier is not binary. And this is one of the problems we have. Patients believe it's binary. I have a low score, I'm not going to get metastases. I have a high score, I'm going to get metastases. Of course, that's not true, right? This is just tipping the scales a little bit. This is the Weather Channel, narrowing the band of where the hurricane's going to make landfall, okay? And so how does this translate into practice? I mean, here's another one of the tests. You talk about the Oncotype clinical utility study. What did they do? They looked at pre and post GPS, what percentage of patients elected for active surveillance. So going on active surveillance, of course, is not a clinical outcome. It's just a decision, right? Again, this is the decision-making process. Doesn't change the patient's survival, right? Changes their short-term mortality, but it doesn't change the long-term outcomes. And what they looked at is they said, all right, let's say prior to getting the test, if you just use NCCN guidelines versus, your GPS score, what do the urologists recommend? So over here you see, without the GPS score, 91% of patients with very low risk disease are being told to get their test, 80% with the GPS. And what it translates into is actual decision making for the patient. If they have a GPS score, patient follows your recommendation. If they don't, 30% of patients drop off and don't follow your recommendation. In the low-risk group, here again, 62% to 63%, patients listen when they have a GPS score. Patients don't listen as well when they don't have a GPS score. So again, the point of the test then is not to change clinical outcomes. That's not how it's been validated. It's been validated to say, if you get a test, patients will listen to you, and if you don't get a test, patients won't listen to you. That's the validation for the test. So ultimately, what I would say is, we should be honest, what are we ordering these tests for in terms of these genomic classifiers, right? Do they meet the principles approved, for example, for germline testing? And the answer is they don't really translate into clinical utility or clinical significance. What we're doing here is we're saying, well, we tell our patients, here's what I recommend, but either we're not convincing them well enough because they don't trust us, or we don't trust ourselves to really tell the patient, no, I mean, truly, I believe this, you should go on this treatment. You should have active surveillance, you should have adjuvant radiation, right? Part of it, of course, is, patients want the test that their neighbor got, and maybe you lose face if you don't give them what they want, right? I mean, this is why we have the opioid crisis in this country, right? They don't come back to you if you don't give them the opioids they want. So we order the test because we want to protect our practice, because we want, patients to trust us. And I think ultimately, physicians, urologists, oncologists, we need to do a better job really having confidence in what we're recommending to patients, not lulling them into a false sense of security. I think as providers, all we really need to do is, anyways, that's the end of my talk. Thank you.